Hey, we got matching pants on. Look.
I love it. I love it.
Flannels. High five.
No doubt. Welcome in, everybody. Thanks for joining us today. All of you guys on Zoom, I appreciate your attention and your time today. We've got a good layout for you here. You folks over on Facebook Live. Some of you haven't joined in yet. This will be recorded per the permission of Dr. Geoff Bove, who joins us here today. You will find that recording on my blog at neurocentricapproach.com. Before we get started too much and I introduce Geoff to those of you that don't already have a decent understanding of his work, let me allow me to have just a wee bit of commerce time here. Those of you over here that aren't members of the NeuroCentric Approach Online Academy, we have a lifetime membership kind of situation available there. You pay one time, you get me for the rest of your life, whether you like it or not. And that online, that will give you, with that one payment, all access to all current online continuing education products that I have out and all future. And it will give you $100 off of any of the in-person courses that we have. Our next course is in Seattle. That's going to be February 10 and 11, I think. You can check this on the events tab at NeuroCentric Approach. And I'm announcing today as well, that will be our lower quarter course. That's a 12-hour continuing education course. And our next course after that will be in April. You can see the dates on that. That's going to be in Seattle. That'll be the upper quarter course. So you Pacific Northwest folk can come and join us and get both of those. And then you can show up on the NeuroCentric Approach online site in the locator map. Why is that important? Because candidly, guys, as you use this in practice, as you use this approach that folks like Dr. Bove and I have been using for years, it will change your outcomes. And as you change your outcomes in that way, word gets out. So people are going to be looking for you. And as this steadily grows over the time, this is a foundation and a ground floor opportunity for you to get involved. Okie doke. That's enough of that BS. That's selling stuff. Today, we're here to talk about science and promoting it in a solid way. I'm very pleased to have Dr. Geoff Bove on with us. I've been following Geoff's work for most of my 20 years in practice. He is probably the OG in neurocentric kind of treatment out there. I believe Geoff retired in the last couple of years from his faculty position at the Osteopathy College. Is that a negative? Then it's been.
No, I quit and told him to take a hike off a short pier. I'm still funded by actually the Massage Therapy Foundation. My lab is right there.
Yeah, I saw
on the other side of that wall.
I saw some of the at least one news post about you that you've moved all of your mice and your lab into your garage and have a legitimate research facility going on there. Geoff is a noted researcher. He's probably been the main one that I'm aware of that has carried over some of the ideas of some of our founders in the profession of chiropractic and updated them in a way that really shines a light on what is happening to neurology in our patients and how it can become sensitive and drive motor programs, etc. Those of you that are interested in his work, one of the simple and easiest ways for you to access his peer-reviewed research is to go to ResearchGate and just toss his name in there. And you'll find when you do that, Geoff says in chat, those of you that are on here in chat, you can see a link that he just put on to bovelabs.com. And it's Bove, people, not Bove. So it's BOVELABS.com, and all of his papers are on there. One of the other things that I've liked about Geoff's work over the years is he puts those papers on more often than not as open source. So you don't run into too much of a problem. You can get a lot of good information there. I'm going to get out of the way here. You guys hear enough of me babbling every week. So, Geoff, take the floor, talk about what you like.
Well, what I like nerves. Oh, I'm serious. I love nerves. I like them right when I started. Well, I liked them before chiropractic college, but I loved them in chiropractic college. And I think we're working on nerves one way or the other. I love dissecting. I like looking at them during surgery. They're really beautiful. I like them. So I ended up going to, the stories. We all have our own little stories of how we did things, but in practice, I wasn't very happy. I just didn't think I knew enough, and I didn't like the 80% of practice that is not involving patient care, the business parts. So I went to University of North Carolina, Chapel Hill to study specifically. I wanted to open up a line of research on the effects of inflammation on peripheral nerves with an eye towards a different hypothesis of visceral homeostasis. And that goes back to nerve pressure, nerve interference, and innate. And that's what influenced the ideas to go actually pursue that. And it was very early on. I was teaching gross anatomy right when I started there. And I had a cadaver that first year who had died at the age of 50. The woman had died at 53 with Huntington's chorea, and she didn't have an adipose cell in her body. When I took off the chest plate and moved her lungs back, I could see the entire sympathetic chain with the rami communicantes, the azygos system, just all laid out there behind a nice shiny layer of mesothelium or fascia, whatever we're going to call it, peritoneum. And I didn't get pictures of that, which I really wish I had. Since then, I started looking at the older cadavers would have a lot of osteophytosis in that area, and these would be pressing into and deforming the sympathetic chain and the ganglia. And my work kind of evolved around first, initially, I was going to characterize what paraspinal nociceptors responded to. Because at that point, no one still has published any paper about. Mensa's done some recent with fascia nociceptors, and he did a lot of muscle nociceptor work early. But at that point, I rediscovered the nerves of the nerves of the nervi nervorum. This is now people have run with that a little too far sometimes. The nerve supply of the nerve sheaths themselves. And as control experiments, once I got my own lab a few years later, as a control experiment, I was seeing whether those were just sensitized axons or what was going on. And I did discover that inflammation changes axons to make them behave like their native receptive fields in the deep muscles. It induces receptive fields right directly on the axon. So anyway, and over the last 10 years or so, I've grant-wise had to go away from strict neurobiology research and just into other stuff. But that's what I'm talking to you about, is things that I've learned along the way in that path. And
Thanks, Geoff.
And more than that, the case study, which exemplifies the whole work.
Yeah, and I think a good place well, probably before I say anything else, I'm looking out a window on the other side of my computer here at probably 30-mile-an-hour gusts and pretty good snowfall. And Geoff has similar interesting weather in Kennebunkport right now. So the possibility is that the lights could go off. We'll just imagine that the gods at Asgard, this is a tumultuous event right now that we're having today, and we'll put our own egos in there. But if we do happen to go down, Geoff does have a backup generator. I'll do my best to try to see if we can get things going back up and soon. But if not, then we'll revisit this on another day. Geoff, I think given that most of these meetings that we do are case studies, I think what you just provided a lovely segue for is we could use this case that you recently published in the Journal of the Canadian Chiropractic Association, I believe it was, and use that as a jumping off point, because I think it's a nice way to take your work out of a mouse or a rat model and see how it works in a case with a human being. And perhaps as you go along and talking about it, you can sidebar just a little bit and relate it to some of those other papers that you published in the past and how your thought processes built up to why you did the things that you did in clinic with this particular patient.
Okay. Now you have to remember, I haven't seen patients full-time since 1989, and I didn't like it full-time. I saw a lot of, I did locum tenens for people while I was in grad school. So I worked in 25 different chiropractic offices about 6 weeks a year. And I saw everything on the good, bad, and the ugly side there, practice-wise and patient-wise. And so I see patients once in a while. I've tried that office before it was a lab. I built it for a practice, but the realities came back to me of billing and trying to get paid. So I see patients once in a while. The case that I published, first off, it was the most miserable thing to get published. It got rejected everywhere, mostly by people who can't accept the concept that axons can do anything except send an electrical signal. So it wasn't about the treatment at all. And I wanted to try to publish it without the treatment, but I knew that would never happen. The only way this got published at all is that the editor-in-chief of Journal of the Canadian Chiropractic Association knew my work and also knew enough to send it to a reviewer who to Brian Budgell, and you all should know him too, as a reviewer. I'm not sure who the second person they sent it to after it went through many trials, but it was just getting rejected for, no, this idea that it's related to what it's related to is just wrong. So the way I met this person is also kind of interesting. It was a couple days after Christmas, and I was in Chicago with my spouse and a friend from Chicago, and we're in a bar, and I'm up getting a drink, and I said hi to this nice looking two people that were there, and I went back, and then when I was up on the second one, I was waiting a long time, and I said hi again, and the young woman, she's like 24, asked me what I did, and I told her I was a pain expert. And she said, oh, I have a pain problem. And I said, what is it? And she goes, oh, they tell me I've had shin splints and it's been 11 years. And I said, well, how did it start? She said, I'm a pole vaulter. I said, it's your psoas major. That was it. And then I gave her information to contact the anatomy professor from where, forever, Greg at National.
Dr. Kramer?
Greg Kramer, yeah. And I said, he'll find you a chiropractor. This is going to be, probably. Well, she found me and emailed me the next day, and we ended up having a FaceTime exam with her mother doing it. And it was absolutely nerve, and it was nothing in her shin. So I sent it to a chiropractor who wouldn't listen to what I had to say and told her that I was just a researcher and didn't know anything. So that was fun. And then I said, I haven't actually examined you. And she said, well, I haven't ever been to Maine. So she and her mother came here, and I did an exam over there on my portable table. And it was very clear. And the kicker, if you all looked at the case, that made this worth publishing, it was just the circumstance that if I pulled on her femoral nerve with a femoral nerve stretch, that's L2, 3, and 4. And then I pulled on a sciatic nerve with a straight leg raise test. That's, I don't know if I can do this, right? That's 4, 5, and S1 and S2, right? So they're both pulling L4. There's the diagnosis. It was actually, that was it. I checked everything else. I did ultrasound of her femoral nerve down her, with her saphenous nerve. I tested everything else. Her back was locked up like crazy. I actually got the x-rays and the MRI later after she had a response, just so I could have something I thought to help publish things. I have no idea why. I mean, I just have an idea of why she'd have gotten better so quickly. I think, I really think we break adhesions, nerve to intervertebral foramen adhesions, if we get it right. Otherwise, I mean, there's no neurological explanation for what we all see, at least all of us chiropractors see, which is this immediate response to a treatment. And the only thing I've ever been able to figure out, and I've presented it at the Fascia Congress, so that maybe we're busting something that was providing the noxious stimulus.
You know, it's fascinating to hear you say that. I know that we've had reports, and I've seen very dramatic, similar kinds of improvements in working in the periphery with nerves, especially around the shoulder and especially around the knee, working with suprascapular and the saphenous nerve most commonly. And doing what we refer to as transverse nerve mobilization rather than getting on the nerve and mashing it, like everybody else seems to be doing, using that as diagnostic for where we might need to be focusing our attention, and then getting lateral to that, going deep to that, and then pulling and or getting on the other side of it and pushing while the patient moves and does some flossing, and then doing a lateral transverse nerve mobilization. I always try to envision it like it's playing guitar and you're trying to fret and bend a note. And as we do that, in some patients, you'll get an audible cavitation that seems to be a suggestion that something is giving way in that process, and immediately they have an improvement in range of motion and they have an improvement in pain. And that's not a joint that we're actually moving and cavitating at the time. So fascinating to hear your thoughts on that.
Well, and the cavitation, to me, is we know that's increased with increasing the range of motion, and maybe it just needed that extra little amount to bust something up. Nerve adhesions in the IVF didn't exist until there was a product to treat them, by the way. So in 1990 and 91, I asked Elizabeth Bullitt, who's a neurosurgeon researcher at UNC Chapel Hill, about this. And I asked a couple neurosurgeons, and they said, no, there's never any adhesions in the IVF. And it turns out they all stick something in there and clean it out, always, when they're in there. They'll to separate scar tissue and fibrous tissue and that. But then something came out called Sepra film, and then Adcon L. Then all of a sudden there was all this talk about adhesions everywhere on nerves and IVFs. It didn't work, but so I've had that same experience with, and that was with treating a number of patients using information largely from Michael Shacklock's idea, and he and I have gone back and forth over the decades with finding the where the nerve goes through a hole. That's a susceptible site. And I've given lots of talks about where our nerves likely to be. And if you look at the handbook of, I don't know if it's the handbook of peripheral neuropathies or whatever, they always are at fascial foramens, where they go through you know, a nerve goes through a hole like this, and you don't know where that's going to be. And that's why if I were in practice full time, I would have a high quality ultrasound unit. And I'd have one here right now with me, except UNE stole that one from me when I left. And the last thing I used it for was on this case, is tracing her saphenous nerve down. And if you get good with those, I could see a cluneal neuroma on my father that had been induced by a trigger point injection and caused a lot of true neuropathic pain. But you can, it takes a while, and then it kind of gets boring. You can see peripheral nerves really, really easily with the ultrasounds now are specifically made just for peripheral nerves. They're tuned for it. And I had a Sonosite M Turbo, and that probably costs close to 100 grand now. I don't know
Yeah,
if
that I think you may have just answered a question that popped
I
up.
did.
Yeah.
But it's a matter, you need a high frequency, you need like a 12 to 16 megahertz transducer. That came out. I mean, you need a high frequency one. The more ultrasound's not good, it gets worse the deeper you go. But in some, I talked to a person at the Dallas conference, a naturopath who does ultrasound guided hydrodissections of nerves.
Mm-hmm.
That scared the heck out. I mean, I know I don't, that doesn't bother me, but I'm afraid they're sticking, like injecting nerves by accident, and they will if you don't use an ultrasound, that's for sure.
Yeah, that your personal or tangential experience with your father was certainly educational in that in that realm, and seeing the downside of it. And but I have more than a few times considered the possibility that if at some point, if I decided to go back to school to do anything, it would probably be to get a nursing degree and a NP degree so that I could actually do exactly what you just described. Partly out of frustration, because I don't have, I find that the physiatrists that I work with, they don't know this material very well, and they're not all that interested or economically motivated to, use something like that. And the pain, then the other docs that are moving into regenerative medicine are more interested in devising some sort of cocktail of exotic compounds that they can charge a lot for, rather than just using something that's relatively inexpensive, like normatonic. And use the saline from a mechanical perspective to try to change that interface point.
Yeah, I went to the last fascia congress I went to for various reasons, including this. They're never going to invite me back. I put up the slide after being the chair of the science committee for every one of them. I put up a slide, said, it's not about the fascia. Big slide. It's not about the fascia. And then I said, it's about the interfaces.
Yes.
I really, truly believe that, but I can't prove it any more than, I mean, we could probably prove it. And I think case studies with hydrodissection could possibly go there, or case studies in general are going to help, but they have to be focused on that in the first place. And so there's a catch-22. Like that's why I thought that case study, most people look at that case study, and when they read the punchline of what the diagnosis was, they say, oh, I see that every day in practice, or I see this all the time. And then my response is, but she went 11 years to different chiropractors, PTs, medical doctors, and no one looked beyond the shin. So, I mean, I didn't think I was any big genius here for doing a straight leg raise test on her.
Yeah. Yeah.
Or listening to how she developed the problem in the first place.
Well, it's, in conversations with Michael Shacklock over the years, that was always one of the drums that he and I would beat, is that, if you're not looking for involved neurology, you won't find it. And, once you just decide to look, you don't even have to be all that great. But but it really helps if you do ascribe to some of the findings and some of the research out there to suggest that there are better ways to do that. And that's the vanguard that Michael has tried to push over the years of getting clinicians to be better at doing that kind of assessment of the peripheral neurology.
Well, the biggest limitation that I've seen over I mean, again, I had Michael come over the first time. I had him visit and give a talk when I was in Denmark. So that was in 1996 or 97. It's not difficult. You have to learn where the nerves are. And you have to look every time and take the time to look at the nerve anatomy. And I say that with having thought about that for 30-something years in the anatomy lab, and that's very different. And every now and then I've had an opportunity to do at Canadian Memorial Chiropractic College. I did a course, a day-long course, and it involved going into the anatomy lab to look at nerve interfaces. And so we went through, and I just led people through and said, this is where that nerve could be affected. And if you know that the axons in there can get affected, like, look, here's an osteophyte pushing on that nerve. That means it's inflamed as an innocent bystander. That means that that person probably had mechanically sensitive axons right there that they would feel the sensation down in the innervation territory. And they go, oh, but I've only gotten to do that once.
Yeah,
And
I had a similar experience early on in practice where one of my former profs at University of Western States, Michael Carnes, who had previously been an anatomy instructor as well, he and one of my other instructors, Charlie Novak, like to bring those names up for some of you UWS folks to smile about. But they put together a similar kind of program in the anatomy lab. So they did a didactic and they showed Bob Elvey's papers at that particular point in time on neural tension testing and described the mechanics. And then we go into the lab and gowned up and looked at prosected specimens and put them through. And a lot of lights came on at that point, looking at those potential interface points, those hiatuses, hiati, I don't know. Those holes, the grommets where the nerves come through.
Right. The grommets, yes.
How that.
And by the way, they can raise what Zach Brown has mentioned in the case here. Rather than learning how to try to floss, and I'm frankly not I don't buy it so much, to tell the truth. I think that you can put people through the maneuvers of flossing, but you don't know, unless you had an ultrasound, you don't know if that nerve's moving. And on me, for instance, one of the other reasons I got into this is that I was a dancer for a short period of time, and my nerves don't move. They get tight and they limit movement, period. And I have a little editorial thing in Dance Teacher magazine from long time ago about this. My sister wrote, she was a dancer and teacher for a long time, about how if there's a kid on the bar that says it hurts, ask them, it might not be they're not working or not stretching enough, and they might have nerve stretch related pain, especially if they move their head and it triggers it, like a slump test. But if you take a lot of especially flexible women, you never get a sciatic nerve stretch enough so that it's symptomatic. So there's so much biological variability in people. You can't just, go like this and think you're flossing the nerve unless you bring it out to a pain point and then bring it to a non-pain point. And that is probably flossing the nerve. So that question about flossing a dorsal scapular nerve, first off, dorsalgia, and I argued about this with my chiropractor treating something like this on me. The dorsal scapular nerve is a purely motor nerve. I'm pretty sure. And this is the kind of thing I say, and then I have to go look it up because no one can remember everything. But so it's not carrying nociceptive information. It can't if it doesn't have sensory fibers. I'm just giving you an example. You have to look up the specific nerves, especially in that area, and know whether it's sensory, motor, or both. I'm pretty sure that's purely a motor nerve. So getting in there with your fingers, you might be able to find it. you're not going to palpate it, but you might be able to find it. And the idea of trapping it and then plucking it, or like bending a chord on a guitar, I love that. And I think that trying to bust up, that's the other thing. I've got other data sets that show we can't even bust up minor fibrosis.
Yeah.
It's very frustrating. You know, I put a clinical hat on for a minute and then it just ripped off by the science.
Yeah, regarding the dorsal scapular nerve, and this is one that I see and work on and find benefit from, whether the premise and why that benefit is observed off or not certainly remains to be seen. But in leaning into Zach's question, which you guys over here can't see, Zach says, I have a case with what I believe is cervical dorsalgia after surgery, removing a lipoma from her upper TS spine. I have had results with dermal traction, but how might you floss the involved neurology of the dorsal scapular nerve and the suprascapular nerve? As to how I would floss it, I would say something very similar to what Dr. Bove just said. I wouldn't try necessarily to floss it, because your ability to do that is going to be very limited. That said, what I generally see in most of my patients with pain in that mid-scapular region, which you guys will see on the, I talk about in the shoulder pain module that's on the online academy. I usually see a handful of nerves with shoulder pain that is of cervical origin that are involved. The dorsal scapular nerve is one, the suprascapular nerve is another, the axillary nerve, and the radial nerve. And what I generally see is that if they have an index movement that's painful, and typically it's abduction or flexion of the arm, and you just provide traction on the cervical spine and their symptoms improve with that index movement, it would infer that probably playing at the spine would be worthwhile for you to consider. And two modalities that I would most typically use there would be initially mechanical derangement models from Robin McKenzie using retraction methodology, and then static openers from Michael Shacklock. And if I get benefit there, that's great. But usually I'm going to go in and use a TNM, transverse nerve mobilization, along the course of the dorsal scapular nerve. I usually look for two entrapment points in particular. One is the middle scalene, where the nerve pierces the middle scalene. The second is just as it goes under the upper trapezius and starts to head towards the levator scapula. Those are the 2 points I see it shows up in most commonly. And if I've got a patient that says that their symptoms in that area of the mid-scapular area is worse when they're stressed out, then I relate it to their breathing patterns, use of the middle scalenes, and that opens the door for a deeper clinical inspection of that whole process. Comments, Geoff?
I like that. I'm just, I'm in a very jaded, nothing works kind of phase of my life. And I've got, oh, and by the way, you'll get a kick out of this. How many of you guys have spinalators? No?
No.
I bought an antique spinalator.
Oh, sweet.
No, I had one. No, but oh, look at the wheel. And I just set it up with custom cervical traction. See, I've got a little board here, and I guess one of these things. And isn't that nice? And so it's almost too much traction. But I have now, and this is, I told you I've been doing CrossFit for now 3 years. And how many of you have done kipping handstand push-ups? I think maybe Zach, based on his arms. No? So none of you ever do kipping handstand push-ups. I just published a paper on the axial loads of that to the head of kipping handstand push-ups. And I was doing them because it makes you feel like a, Olympic hero and shit when you're in a CrossFit class. And I hurt my neck. And now I have, when I do this, my C4 slides off my C5 a little, and my C5 slides off my C6 a little. And I've had other neck injuries, but now I've got a nice paresthesia that, like right now, a little prickly paresthesia, which if I didn't know what it was, I'd think it was great. Kind of feels good. And I'm just waiting for things to start atrophying. So I've been trying this intermittent segmental traction with cervical spine stuff, and I don't think it's going to do anything. So I'm a little unstable here. So I have posterior scalene involvement, and I've got dorsoscapular nerve, maybe. That's what Kyle Nagel is, my chiropractor, who told me that you posted this on Facebook. So anyway, nothing's been helping. And he's been doing a lot of active release on, some on my posterior scalene, and going on the concept, like, let's make room for the nerve everywhere. So working in here and working up here. And he's a little hesitant. He's a really good adjuster, but he's a little hesitant with it. But it's just I don't have any pain. So that's a long-winded way of asking the group, why don't you think I have any pain? I have obvious, an MRI, X-ray showing unstable cervical spine. I'm 63-year-old with a history of neck, frank neck injury involved. One time I fell off a bike, mountain biking. I went like head first into luckily a very rotted log instead of a rock. I had a helmet on, but still, that's like 12 years ago. Banging my head doing handstand push-ups, which I won't do anymore, of course. So I have a non-painful C6 ridiculous. Oh, MRI shows encroachment. So why don't I have any pain?
It's an excellent question. You're the nerve researcher here, Geoff.
I don't have any pain because that's not inflamed in my IVF.
And that is where I was hoping you were going to go here, because I think that's going to be a really nice tangent for us to explore a very common theme over the years in your research, this concept that inflammation causes the downstream observed phenomenology that we see clinically, whether that's a change in the receptive field, whether it's a change in pain, or whether it's a change in motor. Go with that.
Okay, so it's not an idea, it's multiple repeated experiments in not just my lab, but also in the laboratory, Andrew Dilley, who started with Bruce Lynn to scoop my ideas back 20 years ago. And then he got one paper in pain, and then they ran out of money. And I hired him, and we're working on a paper now. We're working on a summary of the work for a Journal of Physiology right now. So that's good. It's just that we've been frustrated. More people haven't picked up on the other labs, especially, but they're almost impossible experiments. That's the other part. There's only a few labs in the world that can record from single file, do this kind of experiment, especially from deep tissues. So, yeah, it's not about the skin. I mean, how many of you guys treat people with skin pain? It's like, no, there's a few main causes of skin pain, and they're both, postherpetic neuralgia. Okay, prevent getting, that sucks, but hopefully the vaccine worked. And diabetic neuropathy, and we know the cure for that is, don't let people get out of control diabetics. And there's, peripheral neuropathic pain, which is actually pretty rare. Most nerves get cut. Like every time you have a surgery, nerves get cut, and they just heal up, either numbness or they heal up okay.
Can you let me interrupt for one moment, Geoff, because a common question that I get from patients that I think other docs do as well. You mentioned like diabetic neuropathy. talk a bit about the healing capacity of the nerve once it's been exposed to that kind of environment and it's screaming out and it's painful. What's the healing potential for that neurology once we actually change the systemic situation that it's being bathed in?
I don't think there's any reversing diabetic neuropathy, because there's also basement membrane changes from basically having sugar all the time that have thickened everything up and strangulated the nerves and their fascia. I think that's, but with people with nerve problems, if they haven't developed fibrotic tissue within the nerve, I think there's almost unlimited potential for healing up if that can be somehow neurolysed. I have a friend at the gym who he's a drywaller and he goes numb and hurts here. Guess what the diagnosis is, right? So 20, 30 years of spreading drywall mud and stuff. He's just overuse injury. And I actually examine him from the head down, and he has the most purest form of carpal tunnel syndrome there is. You know, leave it there, it goes, leave it there, it goes. I go all up and down everything, there's nothing. And today he told me that the numbness and tingling is gone, but it's just pure pain. And with my research and the background, I said, well, now the inflammation and the pressure is gone off the nerve, but the effects of that inflammation are going to, assuming it doesn't get reinitiated, it's going to take 6 weeks or so for the axons to heal. That's what we published. We did a study specifically on that, and I just spitballed 6 weeks out there. But if you remove the inflammatory or the initiator of the inflammation, things will go back to normal in usually, you know, weeks to months, a few months. If there's axon breakage, that won't necessarily heal, especially if the axons, if there was an injury that caused fibrotic tissue, axons like to stick into fibrotic tissue. That I could get into a whole separate lecture on what I think, and I wasn't able to try to do the experiments on with nerve regeneration, like after a nerve crush. Well, I can mention that if I do another experiment, it'll be the effect of manual therapy on nerve regeneration. Right now, the study that I'm completing is the effect of manual therapy on post-irradiation fibrosis. And I had a major problem with the experiment because the dose of irradiation that I used previously when I was working with Mary Barb, that was effective to cause the fibrosis. When I brought the animals here after the irradiation, they didn't develop the fibrosis. And the only thing I can think of is that in the laboratory at Temple University, the animals are singly housed, so all they do is sit around and eat. And the animals in my lab are in groups of 4 with a tunnel, and they run around and play with each other all the time. And I think the only thing that's different is added mobility. And so I think they just mobilized themselves and didn't get the fibrotic changes that I expected. So that experiment kind of has gone belly up, and I'm not sure the funding agency is going to say, I think they're going to say, well, he kind of messed up that.
I would toss
any
one
more
more.
rats.
I would toss one more thing in there, the possibility, and I guess in some papers that parse the rats or mice into different cohorts would refer to this as environmental enrichment. I'm thinking of some papers I'm aware of by James Treatise, and that where this environmental enrichment, which is commonly referred to as exercise by most of us in this particular area, that if we take a gander at some of the longevity research and look at systemic causes of the potential irritability of nerves and the development of fibrosis, then you can see some associations with high oxidative stress environments causing that, or having, I won't say causing, being associated with that.
Okay.
And one of the ways to ameliorate some of that oxidative stress is to have some environmental enrichment, get out and exercise a little bit. So perhaps that was creating a bit of an issue. Maybe at Temple, your rodents were bored and depressed, and they got some community and some exercise. And when they came to your house, and lo and behold, they felt better.
It's not, it's a, if any of you have ever had rats, I mean, they're lovely, interactive, outgoing creatures and exceptionally sociable. The woman who has that I wrote that case study about, I asked her to be on this today, and she on a train somewhere, but she got rats after she had been here, and she has them trained. They use a rat box, and they go outside the cage and go back in. I mean, they're just great little animals, but they get lazy and they'll gain a lot of weight. Mine didn't gain the same weight that they normally would if they were in a lab isolated. I put them in duplexes and connect them with a runway, and they just run around like a lot and tumble and play.
Habit trails.
Yeah.
So Geoff, let me bring you, let's bring it back around a little bit to some clinical stuff that I would love your vantage point on. We've briefly touched on your notions of inflammation in a nerve and how inflammation at one point in a nerve can change its behavior and the subjective experience of the individual feeling that downstream. We also have evidence. I remember having a phone call with you a number of years ago, and you bemoaning the fact that we've been chasing the rabbit for many decades on what the actual physical change is in a nerve that causes it to become mechanically sensitive. What is the channel? What is the ligand? And, you know, since that conversation now, Artem Patapoutian has had a Nobel Prize for his research into piezo-1 and piezo-2 receptors.
Irrelevant.
Okay, that was one of the comments I was expecting to hear from you there.
They don't exist in nociceptors.
Understood. Now, in regards to how nerves are, peripheral neurology is affected, you mentioned inflammation, and that inflammation, even in some of your study designs, can be created either by mechanical stress of the nerve, with your axoplasmic flow model where you ligand nerves, or you can, I believe, use Mycobacterium tuberculosum in some of those to create an inflammatory environment for a nerve without changing the mechanical structure of the nerve. We have other papers from like Kobayashi and others that show us that a nerve will become painful, or a painful nerve we will observe to have reduced blood flow in the vasa nervorum. And that when we restore the blood flow in the vasa nervorum, very quickly the nerve downstream becomes less painful. We've got David Butler referring to ectopic generation points and abnormal impulse generation points, which your axoplasmic flow research kind of leans into. I'd love for you to talk a little bit about these various ideas of mechanical stress and how it blends and maybe can be independent of inflammatory changes and vascular changes in the nerve, and how that plays out clinically. And
I started out by inflaming the nerves as opposed to trying to find a factor, because I'm not interested in drug work. I asked, okay, let's throw some inflammation at it. I've just observed things. I haven't done many experiments in my career. I just do things and observe. So I observed what happened to the axons, the function of the axons when they were just very strongly inflamed. And they developed mechanical sensitivity, and they developed, keep in mind, the group 4 putatively or likely nociceptor afferent axons became mechanically sensitive. None of the cutaneous axons from any class became mechanically sensitive. No muscle spindle axons became mechanically sensitive. Just the ones to deep structures. Just the ones that give you a straight leg raise test that's positive. And by the way, right there, I'm going to make a quick little tangent. If you have a straight leg raise test that's positive, and it also, I mean, so it reproduces pain, deep pain, and it's always going to be deep pain. But if for some, not always, but let's say you develop, the person said they do feel something on the skin, you should start thinking about broken cutaneous axons being sensitive where they're trying to regenerate. Oh, and that's not going to get better. That's just plain not going to get better. We have a paper, I did a paper on this. We had 16 patients or something come in. They all had known radiculopathy by MRI, and I did straight leg raise tests and asked them where they felt the pain. And no one felt any symptoms in the skin at all. Not one leg had symptoms generated in the skin. So when we had that full-blown inflammation and we had these changes, I said, okay, so why is that happening? And what am I going to do? Like do a partial inflammation, delete tumor necrosis factor, delete an interleukin, delete. The body will compensate anyway, as now we know from TNF alpha agonists and rheumatoid arthritis, the body, you know, does something else to get the inflammation going. I said, well, reduced axoplasmic flow is a component of inflammation. It's also a component of chiropractic philosophy. So I put on chemicals that are anti-inflammatory, but cause reduced axonal transport. I mean, they just block fast axonal transport. I got the same results, except they caused the axonal mechanical sensitivity, but it didn't cause the ongoing activity that's associated with inflammation. And again, it was restricted to the deep neurons, only the axons that go to deep structures, only the sensory axons that go to deep structures. So from there, now I'm getting right to your question, which I've lost the thread a little bit. Hold on. Okay, so if you press on a nerve statically, it just kind of makes it go numb. But if you hold it long enough ischemically, it's going to start to get inflamed. And if you put that nerve through a little bit of a pressure site and then move it, which is what we're doing every time, that's going to get inflamed. Even if it's not, it'll generate inflammation. So the compression, ischemia, inflammation is probably not separable in most cases. Although here I am with a pure sensory intermittent, like maybe an hour or two a day, intermittent, maybe not that much, just a little tingly thing that's positional. Like if I could probably evoke it if I do that, but no pain, no nothing. So I've got, it's probably, it'll start, you know, probably as it encroaches a little more and more. But for the most part, Göran Lundborg, a long time ago, published tons of papers about stretching nerves and reducing perfusion through the vasa nervorum. Jeffrey Bernstock published a number of papers on the nervi vasorum nervorum and how they're sensitive to ischemia. The blood supply in the perineurium is very well developed. And it's kind of hard to make. Well, one thing you have to keep in mind with the nerve anatomy of the blood supply is that it's not just anastomotic, it's redundant in terms of both sides. So a feeding vessel goes in and it goes that way, and there's another feeding vessel that goes this way. So if you press in between them, it'll only be ischemic right under where it's been being pressed. It won't be ischemic downstream, for instance. So it's very hard to really render a nerve ischemic. And the connective tissues are really tough as well. So they're designed, if you look at Michael, I think Butler had the same kind of figures, but when you have multiple fasciculations and you press on a nerve, the fascicles can move out of the way to render it immune to those effects of the pressure. actually to get into the axons, deflect the pressure off the individual axons. And in fact, we have more fascicles at places where the nerves get pressed on naturally.
Yep, yep. And I think you kind of answered your
Yeah.
question to the group earlier of why do you have sensory changes, but you don't have pain? I think it's probably a question of the amount of time that the nerve has experienced unremitting compression or tension. And I'm not aware of papers that have quantified, time frames for us clinically to consider in that. But I think that's probably what we're looking at there, that there's basically it's almost like holding your breath. All of us can hold our breath. Some people can hold our breaths longer than others because of training. Some people can't hold their breath very long because of lack of, breathing deeply. It's probably a train phenomena of sorts, kind of like you mentioned that we've got local areas where the nerve is better equipped to manage mechanical forces. And then if it doesn't get changes in mechanical forces, then it will act to try to change the local environment. And how does it do that? Well, it spits out locally in that area substance P and calcitonin gene related peptide and some trophic factors. And essentially, to my eye, tries to create something that for all the world looks like a tenosynovial sheath. It walls off an area around that area of mechanical stress and then puts a fluid interface in there between it. And what in the hell do we call that? I don't know, maybe a myofascial trigger point.
I think we call that what we were planning on talking about, but now we have to do it another time.
No, not necessarily. We could do that at a different time. I'm going to post. Let me first ask: would you be willing to talk longer about this, or would you rather take another day?
We were going to talk about like the clinical importance or relevance of neurogenic inflammation. And that isn't a trivial talk because it's way overblown.
Okay.
I mean, and I have a discussion with Martin Schmelz from a number of years ago about this. And do you know Martin Schmelz work on?
No, I don't.
Because he did all the work. He's in Heidelberg or something, but it's not but it's a longer discussion than, it's past one now. So yeah, I'll do that. And
okay. So shall we, how about then we table that, and if you are keen to it and you don't find this too intrusive in your life or boring, if you do, knowing you just well enough, I know that you will say so. But I would love to continue conversations like this, Geoff, to try to improve the understanding of this type of material to me and to the members of our program and to others out there. Would you be open to that?
Yeah, what I'd like to address at a next one would be the neurogenic inflammation, a concept of ectopic innervation in a case like tendinopathy, and the fallacy of scale, which is my new thing I'm talking about to people, I think. I don't have anyone to talk about, just you guys.
And honestly, mate, that's part of the reason why I put this together. It's frustrating about some of this stuff sometimes to find that you're interested in something that there seems to be relatively few people to be interested in. And I think over here on social media, that's a lovely way for us to use that to parse those people. But then invariably, when the conversation is entirely public, like over there on social media, forgive me, but assholes keep showing up and just throwing all kinds of
Mark.
yeah. And I have very little patience With that, it sucks joy out of my life, and I don't think that it improves me as a human being in any way, form, or fashion. So part of what I'm trying to do is to take those geeks and bring them over here into an environment where we can sit down and have a conversation over coffee, over a beer, and just geek out a wee bit, and not feel too self-conscious about it. So yeah, I would love to have you back again, mate.
Yeah, the fallacy of scale thing has been, do I have a few minutes? Does everyone want to hear something, a little story?
If they don't want to, they are free to go.
Okay, so
But I'll continue this, and we'll keep the recording there, and folks can come back and revisit
it's
it
a good
later.
thing actually to think about for like a lot, I think, for a lot of, so by the fallacy of scale, here's my example. Any of you know Charles Sirhan? So Charles Sirhan really discovered a class of lipid-based mediators that he named resolvins. So the inflammatory cascade, this is a complicated little story, but it does have a good punchline. So if you initiate inflammation, like I cut myself, all these pro-inflammatory mediators start, and the goal is to make it back to normal, right? But you have to have a process that's quick, a process that's slow. You have to have a reparative process. Then you have to shut it off. And a lot of people's problems are they don't have the capability, they've lost, or they just don't have the right chemistry anymore, which already starts raising a little bit of a yellow flag to me, to shut off their inflammation. And David Seaman would say, you have to change your diet. And I've always agreed with his stuff, and knowing him personally for 20-something years, I've always agreed that conceptually it's very solid. Don't be like, if I were inflamed, maybe this would hurt, as opposed to just the most susceptible axons, which are the large sensory axons. They're the most sensitive ones, and the motor ones are next. So as soon as I start losing the ability to do a bar muscle up, I'm going to go get a neurosurgeon, open up that hole. That's the only thing that's going to do it, probably. But so anyway, back to Charles Sirhan. 20-something years ago, he discovered resolvins, and he moves on to lipoxins and maresins, and all these things they're natural chemicals that we make to resolve inflammation. So last June, I was giving a talk or a seminar, and whatever, I was part of thing, and this naturopath came up and asked me some things, and I said, have you ever tried, because I've got the tail end of polymyalgia rheumatica from the shingles vaccine or from the COVID vaccine, which has just been a nightmare. But nothing positive. Just classic pain in response to prednisone. So trying to get off that, I guess. So she says, have you tried these? And I was like, no, I didn't even know what they were. So these resolving mediators are now commercially available, not in very many sources. And they're all based on this man, Charles Sirhan's research. So being me, I'm not going to just go take them. I just start up a conversation with Charles Sirhan, who's probably going to win a Nobel Prize for this. He's won everything else. And he's having a conference on next Thursday. If you look up, the pro-inflammatory mediator conference at Harvard University, I mean, this guy's like every big wheel in the world on this topic is going to be there. And he's, the head honcho. So in going back and forth with him, he's got a new paper that said, well, prednisone mediates it, aspirin, triggers, there's aspirin mediated resolving mediators, there's CBD, everything, and when everything causes an effect, the yellow flag, the yellow flags start turning to orange to me. Then they start turning kind of red. It's like, okay, nothing is a magic bullet. Okay, maybe this is. So I'm taking them, and I'm spending the money taking them, and he's telling me how much he takes, and it's like 4 times more than they suggest. I'm taking them. Then he says you should take EPA and DHA, so I'm taking EPA, DHA. And then I said, what sucks is that I don't know if they're doing anything. But I thought they were. So he said, I'll check your blood. And I said, cool. My wife knows how to draw blood. I've got a really nice centrifuge. So I took 3 samples. One, I had this surgery, and I stopped exercising. I stopped taking everything. And I felt like dog turd. just horrible. Had her draw blood, had it tested for C-reactive peptide and all the other things that, and autoimmune disorder possibilities. Nothing was positive. I waited, didn't send it to him. I started taking prednisone, meloxicam, and the mediators all again. Took another blood sample after a few weeks. Then I dropped off the mediators and took a third sample.
Ah,
Right. Then I'd had all three samples. So it was a good experiment. I had all three samples. And then he wanted to talk. I couldn't tell what was going on. First thing he said to me was to have mediators, the EPA, DHA, and arachidonic, all those so high in your system, you must eat lobster and shellfish every day. And I said, I don't eat any fish product. So not taking the mediators, all my lipid mediators were at high levels, except I don't have lipoxins than I should. And I have a high level of leukotriene B4, which means I'm not converting arachidonic acid over to lipoxin. That's not a deficiency in so basically he told me you don't need to take these. So that was a very worthwhile. But if I look at all the research, there's this is this and this to this and A to B to C to E and all this. I threw a monkey wrench in all that with my serum levels. And the scale is, okay, there's aspirin-mediated lipoxin formation. But how much aspirin, I mean, it's an exogenous product anyway. How much would you need to take? I mean, how much of that system is mediated? That's the scale. So you can't look at all the data points and say they're equally weighted. So my point is, and I'm not ever going to say anything really bad about his work or anything, but it's lost the scaling. It's not absolute. The same with David, and I just lost people I know. But it's like with David Seaman, he reads all this literature, or we all do. You read all this literature and you make all these links, but you have to stop when you don't understand the scaling of something. It might be like A to B, that's a strong thing. Then B to B, not so big. Well, then you got to be careful when you go C to D to F to Q to Z. And that's what I'm getting at with the fallacy of the scale. Like the nervi nivorum story, everyone said, oh, this is why people get Guillain-Barré syndrome, or it is nerve mechanical sensitivity. That's the nociceptors that mediate that. If you press on a nerve and it hurts, you activate a nervi nivorum. If it's hypersensitive, maybe they're sensitized. But we don't know if they exist on little peripheral nerves. And yes, Jerome, I don't have a problem, Jerome, but thanks.
I think I think the process that you just described might be framed as intellectual maturity. I've been witness to other people trying to consume your work, especially in person environments like this, Geoff. And you have, to my mind, a very refreshing way of calling bullshit. And when what you're talking about there with the scaling stuff is, yes, we can be intellectually honest and say that we see an association between this, and this, but you also have to be able to check your own biases and determine whether or not you can say with a lot of veracity, then this, if this, then this. And it doesn't mean that you can't say that and step out on that limb, as the old saying goes, why not go out on a limb? That's where the fruit is. But the limb's also prone to breakage there. And if you're going to be a scientist, as you are, then you've got to build a good foundation, a good strong limb for you to take that step out there. And otherwise you're going to be laughed at by the rest of the scientists that occupy that space that you're working in. Those of us in a clinical environment have to take some level of that hard science and kind of, I think it's right about over there, and work with the N of 1 in front of us and see what we can get. But we also have to be intellectually honest about what we do definitely know and what we don't, and appreciate that that's a sliding scale over time.
And also, if you try to, like, if I want to talk about ectopic innervation of damaged nociceptors, I could create a whole program on that, except the treatment's not anything someone could do. But I could probably get a following, like a discipleship around some things. And that's where, like, the trigger point thing became an out of scale religion that the people involved in that are members aren't going to listen to any data. And we proved that with the publication. Just no,
Yeah.
we're not open to any more ideas. That's it. And like with the kipping handstand push-up paper, I can't get it. I'm having brutal time getting it published because no one wants to hear it. They don't want to let data interfere with their belief system.
Yeah.
It's
Yeah.
pretty
I would push back just a little bit on that, and from an exercise science standpoint, and just look at that and say, okay, so what's your goal with that kipping handstand push-up?
right. Exactly. There's no need.
And what's the risk benefit analysis on the performance of that? And are there other ways of achieving the same goal with a lower risk versus benefit? And that looks like a push press with dumbbells or kettlebells
Exactly.
in my world all day long.
I know that's a no-brainer. Doesn't work at the gym.
Not in a CrossFit box, it doesn't.
Oh my
But
God. No, it's like
that's another conversation.
there's one woman that's doing this when she does them, like hyperextending her neck. She always gets headache and neck ache. She's 42. She's not strong enough to do them, right? And I said, well, here's a video of your neck going into a position that's really bad and looking for banging right down on your head. I mean, now it's just resting on my head. And she goes, well, don't take those away from me. I'm not ever going to stop doing those. I said, you might.
Yeah.
He's right at the level of what's known to cause catastrophic failure.
Exactly. Yeah.
But no one reported any case studies either. So there you go. No one's reported any injuries of the neck during a CrossFit, anything.
But in this environment, these days of cancel culture and everything else, if you put a paper out like that, or even if a journal publishes a paper like that, then they are potentially tacitly supporting CrossFit, doing handstand or headstand kinds of things, and in a jerky, power-laden fashion. And then you're the fact that there's no data on the other side to support or refute that, that's a pure science kind of situation, but it's not a real world situation.
Yeah. CrossFit will be, you can't waive liability.
There's that.
Yeah. They think they can, but if they program something in and someone gets hurt and the paper's out there, they'll go, it's going to be touchy.
So, Geoff, I want to be respectful of your time here. I am going to close things off here, I think. And over here, I thank you guys for coming in. And I really appreciate your attention, your thoughts. I would appreciate you guys that are in the the membership here to drop any questions that you have in the chat. Maybe some questions that we could take up in the future with another conversation with Geoff, if he is open to that. And Geoff, if you'll hang out for a wee bit, that would be appreciated, and maybe talk about future extravaganzas and such. I really appreciate your time. This has been an absolute delight.
Thanks. Thanks for listening, everybody.